Hello, my seminar is about odontogenic infection of the lower jaw. What is the odontogenic infection? Odontogenic infection is an infection that originates within a tooth or in the closely surrounding tissues. Types of odontogenic infection. One of these types is periapical infection. This occurs when bacteria from necrotic pulp or from carious tooth or contaminated traumatic injury move through the apical foramen or accessory canals to the periapical tissue. The teeth involved are non-vital, pain is intense, and throbbing. For diagnosis of this infection, we have three routes. Impalpation, the location of abscess will cause tenderness. Percussion, the abscessed tooth will be very sensitive to percussion, and by X-ray we see the radiolucency in the apical area of the tooth roots. Other type is periodontal infection. This arises from pre-existing periodontal pocket or in some cases by food impaction or repeated occlusal trauma. The teeth involved may be vital or may be non-vital. Acute infection will cause redness and swelling of gingival margin. Pain is continuous, dull and throbbing. The final type is pericoronal infection. This is partially erupted tooth and this is pericoronal infection. So it's associated with partially erupted teeth. Spread of infection represent as two types, cellulitis and suppurative. The difference between them that in cellulitis we not have large amount of pus, but suppurative is characterized by formation of large amount of pus. As we see in this picture, this cellulitis and this suppurative in this form that pus formation and pus discharge is very clear. Infection of space in relation to the lower jaw. We have many space in the lower jaw that infected, but the most common and most important that I will speak about them are submental space infection, submandibular space infection, and sublingual space infection. Submental space infection, boundary of submental space infection from above by mylohyoid muscle and laterally the lower border of mandible and below skin, subcutaneous tissue, platysma muscle, and deep cervical fascia. This triangle is submental space and clinically appear as this form as we see here. Source of infection, we have two sources, direct source from infected lower incisor and canines, lower lip, skin overlying the chin, or from the tip of the tongue and the interior part of the floor of the mouth. Indirect from submandibular spaces. The site of incision extraorally exactly in this area as we see in this picture. Through the skin posterior to the crease behind the chin and intraorally through the mentalis muscle via labial vestibule. Submandibular space infection, the boundaries superiorly by mylohyoid muscle, the submandibular space that bounded superiorly by mylohyoid muscle, inferiorly anterior and posterior belly of digastric muscle, posteriorly by the hyoid bone, medially by mylohyoid, hypoglossal, styloglossal muscle, laterally space bounded by skin, superficial fascia, platysma, deep fascia, and lower border of mandible. Content: submandibular salivary gland, the facial artery, and the facial vein, and the hypoglossal nerve. Source of infection: directly from the lower molar teeth, especially second and third molars, as the infection perforates the lingual cortex of mandible below the mylohyoid muscle attachment. Infection can also spread from the tongue, posterior part of floor of the mouth, and upper posterior teeth, cheek, palate, the maxillary sinus, and submandibular salivary gland. As we see in this picture, this direct source that comes from the tooth. Indirectly from infected sublingual and submental spaces. Sign and symptom clinically appear in this form as a firm or fluctuant erythematous swelling of submandibular region. The swelling bulges over and obliterates the inferior border of mandible. There may be trismus. This obliterates the lower border of mandible. Site of incision: extraorally incision made parallel and about 2 cm below the inferior border of mandible. To avoid injury to marginal mandibular branch of the facial nerve, the incision extends through the skin and subcutaneous tissue only while the space is entered bluntly to avoid structure within the space. In this area, make the incision. Sublingual space infection: anatomic boundary and anteriorly and laterally by the mandible. Superiorly sublingual mucosa, inferiorly by mylohyoid muscle. Medially genioglossus, geniohyoid, styloglossous muscle. The content: sublingual salivary gland, hypoglossal nerve, and lingual nerve. Terminal branch of the lingual artery and Wharton's duct. Source of infection: directly from the premolar and less commonly from molar teeth. When the infection perforates the lingual cortex of mandible above the attachment of mylohyoid muscle. Indirectly from submandibular and submental space. Infection may spread from sublingual to submandibular and pharyngeal spaces. Clinical sign and symptom: erythematous swelling of the floor of mouth that extends through the midline. Since the barrier between two sublingual spaces is weak, usually there is elevation in the tongue. The site of incision: intraorally incision through the mucosa only parallel to Wharton's duct and lingual cortex in anterior-posterior direction and away from the sublingual fold, extraorally through submandibular and submental incision through the mylohyoid muscle. Ludwig's angina. What is the Ludwig's angina? Its massive, firm cellulitis affects simultaneously the submandibular, submental, and sublingual space bilaterally. Clinically appear as these four. There is pain, drooling, and there is bilateral submandibular swelling and tongue protrusion or elevation. Treatments by endotracheal intubation or tracheostomy. As we see in this picture, this endotracheal tube. General anesthesia should be avoided. Early surgical drainage of all infected spaces bilaterally under local anesthesia. Intravenous antibiotic combination of penicillin and metronidazole. Thanks for your attention.